Stroke, what it is, how to spot it, and why time matters. Stroke, often referred to as a brain attack, is a medical emergency that occurs when blood flow to a part of the brain is interrupted or significantly reduced. This deprivation of oxygen and nutrients causes brain cells to die within minutes, leading to potential lasting brain damage, disability, or even death. Understanding stroke, its types, warning signs, and crucial responses is vital for better outcomes, especially for individuals living with conditions like high blood pressure, heart disease, or diabetes, who face an increased risk. The two main types of stroke. Strokes are broadly categorized into two main types based on their cause. Ischemic stroke, accounting for about 87% of all strokes, this type occurs when a blood clot blocks or significantly narrows an artery supplying blood to the brain. Hemorrhagic stroke, this less common but often more severe type happens when a blood vessel in or on the surface of the brain ruptures and bleeds into the surrounding brain tissue. The leaked blood puts pressure on brain cells, causing damage. Hemorrhagic strokes can be caused by uncontrolled high blood pressure, aneurysms, weak, bulging spots in an artery wall, or arteriovenous malformations, AVMs, which are tangled masses of abnormal blood vessels. A transient ischemic attack, TIA, often called a mini-stroke, is similar to an ischemic stroke but involves a temporary blockage where blood flow is restored before permanent brain damage occurs. While symptoms are temporary, TIAs are critical warning signs, indicating a significantly increased risk of a future, full stroke. Subtypes of hemorrhagic stroke, different causes, treatments, and preventions. While all hemorrhagic strokes involve bleeding, the specific location and underlying cause determine the subtype, each with unique considerations for acute treatment and long-term prevention. Intracerebral hemorrhage, ICH. Cause, this is the most common type of hemorrhagic stroke, occurring when a blood vessel ruptures and bleeds directly into the brain tissue itself. The resulting blood clot, hematoma, displaces and damages surrounding brain cells. Primary causes. Uncontrolled high blood pressure, hypertension the leading cause. Chronic, poorly managed high blood pressure weakens the walls of small, deep arteries in the brain, making them brittle and prone to rupture. Cerebral amyloid angiopathy, CAA, a condition, more common in older adults, where amyloid proteins deposit in the walls of small to medium-sized arteries, especially in the brain's outer layers, cortex, making them fragile and susceptible to bleeding. Arteriovenous malformations, AVMs congenital, present at birth, tangles of abnormally formed blood vessels that bypass normal brain tissue. They lack the muscular walls of arteries and the elasticity of veins, making them weak points prone to rupture. Anticoagulant/antiplatelet medications, use of blood thinners, e.g., warfarin, dopes like apixaban, antiplatelets like aspirin/clopidogrel, significantly increases the risk and severity of ICH, especially if blood pressure isn't well controlled or an underlying vascular abnormality exists. Trauma, severe head injury can directly cause bleeding into the brain. Illicit drug use, particularly stimulants like cocaine and amphetamines, which can cause sudden, severe spikes in blood pressure leading to rupture. Acute treatment. Rapid blood pressure control, aggressive lowering of blood pressure is critical to prevent the hematoma from expanding further. Reversal of anticoagulation, if the patient is on blood thinners, immediate administration of specific reversal agents, e.g., vitamin K, prothrombin complex concentrates, idarosizumab, and dexanet alpha, is crucial to stop ongoing bleeding. Surgical intervention may be considered for larger, superficial clots, or if the bleed is causing significant brain swelling and pressure. Options include open craniotomy to evacuate the hematoma or minimally invasive approaches. The decision depends on the clot size, location, and the patient's neurological status. Intracranial pressure, ICP, management, measures to reduce pressure inside the skull, such as administering osmotic agents, e.g., mannitol, or placing an external ventricular drain, EVD, to remove cerebrospinal fluid. Long-term prevention/management. Strict and ongoing blood pressure control. This is the single most critical preventive measure for ICH, often requiring lifelong medication and lifestyle adjustments. Management of underlying causes. For AVMs, options may include surgical removal, embolization, blocking blood flow to the AVM, or stereotactic radiosurgery. For CAA, management focuses on supportive care and minimizing triggers, as there's no direct cure. Careful management of anticoagulant/antiplatelet use. For patients who require these medications for other conditions, e.g., heart disease, the risks and benefits must be carefully weighed, and strict blood pressure control is even more vital. Lifestyle modifications, quitting smoking, avoiding illicit drug use, and maintaining a healthy lifestyle. Subarachnoid hemorrhage, SAH. Cause. This type involves bleeding into the subarachnoid space, which is the fluid-filled area surrounding the brain, between the brain's surface and its protective membranes, the arachnoid mater. The blood spreads over the brain's surface and into the cerebrospinal fluid. Primary causes. Ruptured brain aneurysm, saccular/berry aneurysm, the most common cause, about 85% of non-traumatic SAH. These are weak, balloon-like bulges typically found on arteries at the base of the brain, e.g., circle of Willis. They can rupture, often under sudden increases in pressure, e.g., straining, intense emotion. Arteriovenous malformations, AVMs. While less common than aneurysm rupture for SAH, AVMs can also bleed into the subarachnoid space. Perimesencephalic non-aneurysmal SAH, a specific, less severe type of SAH where no aneurysm is found, and bleeding is confined to the region around the midbrain. It generally has a better prognosis. Trauma, head injury can cause both ICH and SAH. Cerebral venous sinus thrombosis, CVST, a rare condition where blood clots form in the brain's venous sinuses, sometimes leading to SAH. Acute treatment. Secure the bleeding source. The immediate and paramount priority is to prevent rebleeding from the ruptured aneurysm, which is highly lethal. This is achieved via surgical clipping. An open craniotomy, brain surgery, is performed to access the aneurysm, and a small metal clip is placed at its base to block blood flow into it. Endovascular coiling, a minimally invasive procedure where catheters are threaded through blood vessels, usually from the groin, to the aneurysm. Platinum coils are then deployed inside the aneurysm, filling it and promoting clot formation to seal it off. Manage complications. SAH can lead to severe and life-threatening complications that require active management. Vasospasm, a dangerous narrowing of brain blood vessels that can occur days after the initial bleed, leading to delayed cerebral ischemia, a secondary ischemic stroke. Managed with medications, e.g., oral nimodipine, and sometimes angioplasty or intraarterial vasodilators. Hydrocephalus, a buildup of cerebrospinal fluid, CSF, due to impaired absorption, which increases pressure on the brain. May require placement of an external ventricular drain, EVD, or shunt. Seizure management. Prophylactic anti-seizure medications may be given. Blood pressure control, maintaining optimal blood pressure to support brain perfusion while preventing rebleeding. Long-term prevention/management. Management of unruptured aneurysms. For unruptured aneurysms found incidentally or through screening, e.g., in family members of SAH patients, decision for treatment, clipping/coiling, depends on size, location, patient age, and risk factors. Strict blood pressure control, crucial for reducing the risk of aneurysm formation and rupture. Smoking cessation. Smoking is a major risk factor for aneurysm formation and rupture. Avoidance of illicit drugs, especially stimulants that cause rapid blood pressure surges. Regular follow-up imaging, for treated aneurysms or identified AVMs. Subtypes of ischemic stroke, different causes, treatments, and preventions. While all ischemic strokes result from a blockage, the origin and nature of that blockage lead to distinct subtypes, each with unique considerations for management and prevention. Thrombotic stroke. Cause: this occurs when a blood clot, thrombus, forms at the site within an artery that supplies blood to the brain. This typically happens in arteries already damaged and narrowed by atherosclerosis, plaque buildup, which consists of fatty deposits and cholesterol, often referred to as hardening of the arteries. The plaque makes the artery lining rough, promoting clot formation directly on its surface, eventually blocking blood flow. Common locations: often affects larger arteries in the brain, or major arteries in the neck like the carotid or vertebral arteries. Key risk factors: primarily associated with classic cardiovascular risk factors that drive atherosclerosis, high blood pressure, high cholesterol, diabetes, smoking, obesity, and a sedentary lifestyle. Onset can be more gradual or fluctuating, sometimes preceded by TIAs, as the clot may build up over time. Long-term prevention focuses on antiplatelet medications, like aspirin, clopidogrel, to prevent new clots from forming on plaques, along with aggressive management of all underlying atherosclerotic risk factors. Procedures like carotid endarterectomy or stenting may be used if significant carotid artery narrowing is present. Embolic stroke. Cause: this type occurs when a blood clot or other debris, an embolus, forms elsewhere in the body, most commonly the heart or a large artery like the carotid in the neck, and travels through the bloodstream to the brain, where it gets lodged in a brain artery too narrow for it to pass, cutting off blood flow. Common sources of emboli: the heart is the most frequent source, especially in conditions like atrial fibrillation, AFib, where an irregular heartbeat can cause blood to pool and clot in heart chambers. Other sources include heart valve problems, recent heart attacks, or plaque breaking off from large arteries in the neck, like the carotid, or chest, aorta. Onset: typically very sudden and abrupt, without warning, due to the sudden nature of the blockage. Long-term prevention: the cornerstone is anticoagulant medications, stronger blood thinners like warfarin or novel oral anticoagulants such as apixaban, rivaroxaban, dabigatran. These are crucial for preventing clot formation, especially when the source is cardiac, like AFib. Management of the underlying heart condition is also paramount. Lacunar stroke. Cause: this is a small, deep ischemic stroke caused by the blockage of a very tiny artery supplying deep structures of the brain. The blockage is usually due to lipohyalinosis, thickening and narrowing of the small artery walls, or microatheroma, small plaque within these tiny vessels. These small arteries have little collateral circulation, making the affected brain tissue highly vulnerable. Common locations: affects deep brain structures such as the basal ganglia, thalamus, internal capsule, or brainstem. Key risk factors: strongly associated with long-standing, poorly controlled high blood pressure, as well as diabetes and smoking. Onset can be sudden or gradual, and sometimes presents with very specific, pure neurological deficits, e.g., pure motor weakness or pure sensory loss, because they affect a small, precise area of the brain. Long-term prevention: aggressive blood pressure management is the most critical factor, often aiming for even stricter targets. Antiplatelet medications and strict control of diabetes and cholesterol are also essential. Recognizing the signs, ACT-FAST. The symptoms of a stroke often appear suddenly. Knowing the signs and acting quickly is paramount. The acronym FAST is a widely recognized and effective tool for stroke recognition. Face drooping: ask the person to smile. Does one side of the face droop? Arm weakness: ask the person to raise both arms. Does one arm drift downward? Speech difficulty: ask the person to repeat a simple phrase. Is their speech slurred or strange? Time to call 911. If you observe any of these signs, call for emergency medical help immediately. It's crucial to understand that FAST signs are valid for all types of strokes: ischemic, hemorrhagic, and TIA. When symptoms first appear, it's impossible to tell which type of stroke is occurring without medical imaging. Therefore, the immediate response remains the same: call 911. Some experts also suggest BFAST to include balance, sudden loss of balance, and eyes, sudden vision changes, which can indicate strokes in other brain regions. It's also important to note that certain conditions such as seizures, migraines, or low blood sugar can mimic stroke symptoms. This is why emergency evaluation and imaging are essential to confirm a stroke diagnosis. Why every second counts in a stroke. When a stroke occurs, brain cells begin to die within minutes due to lack of oxygen. In an ischemic stroke, up to 1.9 million neurons may be lost every minute if blood isn't restored. In a hemorrhagic stroke, uncontrolled bleeding puts intense pressure on brain tissue, causing rapid damage. Timely treatment, especially clot-busting drugs or procedures like thrombectomy for ischemic strokes, or surgical intervention for hemorrhagic strokes, can dramatically improve outcomes, but these treatments are only effective within specific time windows. For example, for TPA, a common clot-busting drug, is most effective within 3 to 4.5 hours of symptom onset. Mechanical thrombectomy can be performed even later, sometimes up to 24 hours in selected cases, but earlier intervention is always better. After these windows, the risks may outweigh the benefits. The faster you get care, the more brain you can save. What to do if a stroke is suspected? If you suspect someone is having a stroke, immediate action is the most critical step. Call 911 or your local emergency number immediately. Do not drive the person to the hospital yourself. Paramedics can begin life-saving care en route and alert the hospital stroke team. Note the time when symptoms first appeared. This last known time is vital for guiding time-sensitive treatments. Stay with the person and keep them calm. Reassure them that help is on the way. Position them safely. If conscious, help them lie on their side with their head slightly raised to prevent choking if vomiting occurs. If unconscious, check breathing and pulse, and place in the recovery position if breathing. Do not give them anything to eat or drink. Swallowing may be impaired, posing a choking risk. Do not give them any medications, including aspirin. While aspirin can be beneficial for ischemic stroke, it is extremely dangerous in a hemorrhagic stroke as it can worsen bleeding. Only medical professionals can determine the appropriate treatment after diagnosis. Provide all information to emergency personnel upon their arrival. Differences in hospital treatment: why imaging is essential. The immediate treatment in the hospital differs significantly based on the type of stroke, which can only be determined through rapid imaging like a CT scan or MRI. For ischemic stroke, including thrombotic, embolic, and lacunar subtypes, the primary treatment is often thrombolytic therapy, clot-busting medications like 4-TPA, which must be administered within a narrow time window, typically 3 to 4.5 hours from symptom onset. For large clots, especially in embolic or large thrombotic strokes, mechanical thrombectomy, an endovascular surgical procedure to physically remove the clot, can be performed, sometimes up to 24 hours from symptom onset in selected cases. Recent advancements, such as the FDA approval of tenecteplase, TNKs, for acute ischemic stroke, offer a faster, simpler administration compared to older agents like alteplase, as it's a single 5-second 4 bolus. Studies are also exploring extending the time window for alteplase up to 24 hours in specific cases, guided by advanced imaging. For hemorrhagic stroke, treatment focuses on controlling bleeding and reducing brain pressure. This often involves aggressive blood pressure management and, frequently, surgical interventions. These surgeries might involve clipping or coiling an aneurysm, removing a large blood clot, hematoma, or repairing an AVM. If the patient was on blood thinners, reversal agents are critical. It's important to note that while open brain surgery is more commonly associated with acute hemorrhagic stroke treatment, e.g., to repair a bleed, mechanical thrombectomy for ischemic stroke is also a sophisticated surgical/interventional procedure. The key difference lies in the type of surgical intervention and its direct purpose. Long-term effects and living with stroke. The long-term effects of a stroke are highly variable, depending on the stroke's type, severity, location in the brain, and the individual's overall health and the effectiveness of rehabilitation. Stroke can impact nearly every aspect of life. Common long-term effects include physical impairments. Paralysis or weakness, hemiparesis/hemiplegia often affects one side of the body, opposite to the side of the brain where the stroke occurred. This can impact movement in the face, arm, and leg. Spasticity, painful or uncontrollable muscle movements and spasms. Balance and coordination problems, leading to difficulties with walking, standing, and an increased risk of falls. Fatigue, persistent and overwhelming tiredness, both physical and mental. Dysphagia, swallowing difficulties can lead to choking or aspiration pneumonia. Communication impairments. Aphasia, difficulty with language, including speaking, understanding, reading, and writing. This varies greatly in severity. Dysarthria, slurred or difficult speech due to weakness in the muscles used for speaking. Cognitive impairments. Memory loss, short-term memory is often affected, but long-term memory can also be impacted. Attention and concentration issues, difficulty focusing, multitasking, or maintaining attention. Executive function deficits, problems with planning, problem-solving, judgment, and decision-making. Perceptual problems, difficulty interpreting sensory information, such as recognizing objects or faces, or neglecting one side of the body, hemianopia. Emotional and psychological changes. Depression and anxiety, very common after a stroke, often due to physical limitations, changes in lifestyle, and chemical changes in the brain. Emotional lability, difficulty controlling emotions, leading to sudden mood swings, crying, or laughing inappropriately. Personality changes, can include apathy, impulsivity, or irritability. Other effects. Pain, chronic pain can result from nerve damage, neuropathic pain, or musculoskeletal issues due to weakness or spasticity. Vision problems, blurred vision, double vision, or loss of part of the visual field. Bladder and bowel control issues, incontinence is common. Sleep disturbances, insomnia or sleep apnea. The extent of recovery is highly individual, but early and consistent rehabilitation is key to maximizing function and improving quality of life. Physical therapy focuses on regaining strength and mobility, occupational therapy helps with adapting to daily activities, and speech therapy addresses communication and swallowing difficulties. Long-term management and stroke prevention. After the acute phase, treatment shifts to preventing future strokes and maximizing recovery. Medications for secondary prevention. Stroke survivors are typically prescribed medications tailored to their stroke type and underlying risk factors. This includes blood pressure medications, cholesterol-lowering drugs, statins, and various blood thinners, antiplatelets like aspirin for thrombotic/lacunar strokes, stronger anticoagulants for embolic strokes caused by heart conditions like AFib. Rehabilitation. This is a crucial aspect of recovery, often beginning within 24 to 48 hours. A multidisciplinary team, physical, occupational, and speech therapists, nurses, psychologists, etc., helps patients regain lost functions, adapt to new challenges, and improve their quality of life. Beyond medical and physical treatments, psychological counseling and support groups are often crucial for both patients and their families to cope with the emotional and mental health challenges of stroke. It's also important to acknowledge the significant role and potential strain on caregivers, who often provide extensive support throughout the recovery journey. Preventing stroke, a focus on controllable risk factors. The good news is that a significant number of strokes are preventable by managing risk factors. The advice for stroke prevention heavily overlaps with that for managing hypertension and other cardiovascular conditions, as they share common underlying causes. Recent guidelines, such as the American Heart Association's Life's Essential 8, emphasize a comprehensive approach to cardiovascular health, including stroke prevention. Key strategies include: control blood pressure, the number one controllable risk factor, crucial for preventing all stroke types, especially lacunar and hemorrhagic. Regular monitoring, a low-sodium diet, exercise, and prescribed medications are vital. Recent guidelines suggest aiming for blood pressure below 130/80 mmHg for most adults. Eat a heart-healthy diet, emphasize fruits, vegetables, whole grains, lean proteins, and healthy fats, like a Mediterranean-style diet, while limiting saturated/trans fats, processed foods, and added sugars. Maintain a healthy weight. Obesity increases the risk of stroke and associated conditions like diabetes and high blood pressure. Get regular physical activity. Aim for at least 150 minutes of moderate-intensity aerobic activity per week. Screening for sedentary behaviors and counseling on staying active are increasingly emphasized. Don't smoke, and quit if you do. Smoking severely damages blood vessels, increasing risk for all stroke types. This includes avoiding direct use and exposure to second or third-hand smoke. Limit alcohol consumption. Excessive drinking raises blood pressure, particularly increasing hemorrhagic stroke risk. Manage diabetes and cholesterol. Keep blood sugar and cholesterol levels within target ranges through diet, exercise, and medication. Treat heart conditions, especially atrial fibrillation, AFib, which requires blood thinners to prevent clot formation and is a major cause of embolic stroke. Address sleep apnea. Undiagnosed sleep apnea is a significant stroke risk factor. Ensuring good quality and consistent sleep is now a recognized component of stroke prevention. Regular medical checkups, essential for screening and early detection of risk factors. Although strokes are more common in older adults, they can also occur in younger individuals, especially those with high blood pressure, heart conditions, autoimmune disorders, blood clotting disorders, patent foramen ovale, PFO, cervical artery dissection, or lifestyle-related risk factors. Consider social determinants of health. New guidelines highlight that factors like income, housing, and access to healthy food and healthcare significantly impact stroke risk and must be addressed. Sex-specific screenings. For women, specific screenings are recommended due to increased stroke risk associated with hormonal changes, including those who are pregnant or postpartum, had pregnancy complications, have endometriosis, or experienced early menopause. Transgender women taking estrogen for gender affirmation may also require additional screening. Emerging treatments and future directions. The field of stroke treatment and rehabilitation is rapidly evolving, with exciting advancements on the horizon. Newer thrombolytics, as mentioned, drugs like tenecteplase offer faster and potentially more convenient administration for ischemic stroke, which can be critical when every second counts. Extended treatment windows. Research continues to explore expanding the time window for existing treatments like alteplase and thrombectomy, using advanced imaging to identify patients who can still benefit later than traditionally thought. Neuroprotective agents. Scientists are researching medications that can protect brain cells from damage during a stroke or enhance their recovery afterward. Uric acid, for example, is being investigated as a potential add-on therapy. Device-based therapies. Innovations in neurostimulation, like the vivist-impaired VNS system, which stimulates the vagus nerve during rehabilitation, are showing promise in enhancing neuroplasticity and improving motor function in chronic stroke survivors. Artificial intelligence, AI, and machine learning, AI is increasingly being used to improve early stroke diagnosis, predict outcomes, optimize treatment decisions, and personalize rehabilitation strategies. AI-powered robotics, exoskeletons, and virtual/augmented reality environments are enhancing rehabilitation experiences. Telerehabilitation, telemedicine platforms are making specialized stroke rehabilitation more accessible, breaking down geographical barriers. Stem cell therapy, regenerative medicine, particularly mesenchymal stem cells, MSCs, is being explored for its potential to repair damaged neural tissue and promote recovery through angiogenesis, neurogenesis, and neuroprotection. Understanding carotid artery throbbing, a nuance. A visually obvious carotid artery throbbing, seeing the pulse prominently in the neck, is not a direct sign of an acute stroke. It is also generally not a direct sign of carotid artery narrowing, stenosis. Instead, a visually obvious pulse often indicates high pulse pressure, the difference between your systolic and diastolic blood pressure. A wider pulse pressure can cause arteries to expand and recoil more noticeably. Higher overall blood pressure and/or heart rate, even within normal ranges, slightly higher pressures or a faster heart rate can make pulsations more prominent. Arterial elasticity. Your individual arterial elasticity can influence how visibly the pulse transmits. Other conditions, less commonly, it could be related to conditions like severe anemia, hyperthyroidism, or rarely, a carotid artery aneurysm. However, a difference in visible throbbing between the left and right carotid arteries, where one side is significantly less prominent or almost invisible compared to the other, is a more concerning finding. This asymmetry could indeed be a sign of narrowing, stenosis, or another issue affecting the blood flow in the less visible artery, or in the vessels leading to it. If the cause is significant narrowing, it increases the risk of an ischemic stroke if ignored. If such an asymmetry is observed, it warrants a prompt medical evaluation by a doctor. While not an immediate FAST emergency, ignoring a diminished pulse on one side could mean significant underlying carotid artery disease that, if left unaddressed, greatly increases the risk of an ischemic stroke in the future. Your doctor will likely perform a physical exam and may order a carotid duplex ultrasound to assess blood flow and identify any blockages. Conclusion. Understanding stroke, its diverse forms, and its profound impact is the first step toward prevention and effective response. While recognizing the immediate signs using the FAST acronym is critical for initiating life-saving emergency care, proactive long-term health management remains our most powerful tool against this devastating condition. By diligently controlling blood pressure, embracing a heart-healthy lifestyle, managing chronic conditions, and avoiding smoking, individuals can significantly reduce their risk. Furthermore, paying attention to subtle physical signs, such as a noticeable difference in the visual throbbing of the carotid arteries, and discussing these observations with a healthcare provider can lead to early detection of underlying issues like carotid artery narrowing. This proactive approach can potentially prevent a stroke before it ever occurs. The continuous advancements in treatment and rehabilitation offer renewed hope for survivors. In the fight against stroke, knowledge empowers us, prevention saves lives, and swift action makes all the difference. References.